a PhD, and she's from Johnson & Johnson. I do want to thank Ethicon for helping us sponsor this meeting. Dr. Ovington's lecture will not be a CME lecture, but as we always do, we start with some cases. And as is a part of STED Talks, which stands for Spine Technology Education Discovery, Discussion, and Discourse, meaning sometimes adversarial discussions, we don't shy away from complicated topics. So today's topic is complex wound healing problems. And again, Ethicon is our sponsor, and the speaker is specifically going to address the issue of antibacterial sutures, which is the next step in trying to prevent wound healing problems. And spine surgery can be an extremely challenging specialty as we're confronting illnesses and diseases that come on with advancing age and multiple complex medical conditions. And to start us off, we have an ongoing case with a very frustrating scenario where wound healing was not the primary problem, but other problems. And I'll ask Dr. Yev Freevert from UCLA to come up here and show us his first case. So thank you, Yev, for preparing this.
All right. Are we able to load the slide? Perfect. Good morning, everyone. I want to preface this by saying that I wasn't involved directly in the operative care for this patient, and it's a very complicated history. So I'll do my best to fill in the blanks and answer any questions. The patient in question is an 80-year-old male with chronic mechanical low back pain that started in 2002 after a motorcycle accident. The patient unfortunately has an extensive medical history, including factor V Leiden mutation with bilateral DVTs on Coumadin, CKD3, hypertension, hyperlipidemia, sleep apnea, depression, hypothyroidism. Patient was a prior extensive smoker remotely, and he was also obese with a BMI around 35. In 2020, the patient underwent a 3-level Vertiflex procedure and also had a spinal cord stimulator placed as kind of a salvage option for his intractable back pain. Unfortunately, neither of these interventions was effective. The patient also has an extensive surgical history from prior years with bilateral knee and shoulder replacements and numerous femoral repairs, all sequelae of his initial accident. The patient was declined for pain pump placement and further spinal intervention by 2 other spine surgeons by the time that he presented for evaluation. On physical, the patient had slightly reduced sensation in bilateral lower extremities and diffuse 4 out of 5 weakness bilaterally, potentially pain limited, although it was somewhat difficult to assess based on the documentation. The patient was ultimately taken for complete hardware removal, including the spinal cord stimulator, and was revised with an L1 to L5 fusion and decompression. Post-operatively, the patient woke up with a mild new weakness bilaterally in dorsiflexion EHL, but normalized his preoperative baseline within 24 hours. He mobilized very successfully. His drain came out post-op day 3, and he was bridged fairly early back to Coumadin with Lovenox on post-op day 7. Unfortunately, there were some logistical delays in SNF transfer at that point, and on post-operative day 8, the patient became delirious and gradually immobile. On post-op day 10, formal bilateral ankle weakness was noted, and a CT scan was obtained demonstrating this finding, which might be a little bit difficult to see, but it's a very large hematoma or other fluid collection in the post-operative area. As a result, the patient was taken for wound washout, hematoma evacuation, and drain placement immediately. Post-operatively, the patient woke up with essentially minimal motor function below L4, although he did have partial preservation of sensation. Intraoperative cultures were ultimately negative. The patient's drains came out post-op day 4, and he was transferred to a nursing facility on post-operative day 5 with a slight return of distal strength in his left lower extremity at 2 out of 5 in the ankle. Unfortunately, again, the patient came back post-op day 20, septic, with the following images. He was taken for another washout hematoma evacuation and drain placement. And I'm sorry, this slide is duplicated. He underwent antibiotic bead placement with tobramycin and vancomycin. When he woke up, his mental status normalized. Unfortunately, his weakness was unchanged from his preoperative baseline. Intraoperative cultures were ultimately negative, and he was eventually transferred back to SNF on post-op day 9. The most recent update as of a few days ago, unfortunately, is that the patient is essentially unresponsive, headed into complete kidney failure, and likely going to be dialysis dependent if he survives. They don't have a causal organism at present. So I think there are a couple discussion points here. The primary one is the key point after the initial intervention, where the patient's discharge was delayed and he became delirious and suffered sequelae at that point. I think if we had been able to transfer the patient out earlier, perhaps he may have avoided the immobility and ultimate postoperative complications that drastically extended his hospital stay. The second point of consideration is, in this case, all of the patient's comorbidities. This is just one. At presentation, his estimated GFR was in the low 40s, around 41, 42, and for a patient who's 80 years old, that's ultimately a life expectancy of approximately 3 more years, and that's just one of his comorbidities. I think it's very difficult to estimate cumulative life expectancy given all of his conditions, but certainly this was a very sick gentleman. And this patient, based on the documentation, had very classic mechanical back pain that is amenable to fusion. So he was certainly a tempting operative candidate, but I think in this case, potentially balancing the operative reward with the risk may have been something to consider.
So this is a very sobering and important review. Can you go back to some of your slides, please?
Yes,
so
absolutely.
Thank you for putting this together. This is an ongoing battle. And again, one of the key elements of the discussions today will be the focus on diminishing wound infections. And obviously, posterior open procedures in the spine are a setup for infections. And looking at our infections in various committees in our system, I always am kind of impressed with how many of these infections that are labeled as infections are actually not really simply primary wound infections, but are far more complex interactions of multiple organ systems and shortcomings of theirs and or our planning. And every little thing that can happen can set one back. Every missed mobilization, any organ system shut down, like even not being able to eat your normal meals or not having regular bowel movements. For you as a young surgeon who's left a very busy academic practice, what are the biggest worries about posterior incision healing? Why is that so hard to get and to achieve?
Well, I think the primary concern is that postoperatively patients tend to be supine, which compromises blood flow to the surgical incision and limits healing. Also, especially for the patients that are less mobile, and for the lower lumbar incisions, there can be fecal or urinary contamination depending on the quality of nursing. And when the incision is covered from view for the majority of the day, it also limits frequent examinations. So issues are often not caught as early as they might otherwise be.
Mm-hmm. So that's a good initial rundown. Obviously, nutritional factors, vascularity, as we'll see in the next case. I'll ask probably Jerry to get ready for the next case, are other factors. In this particular patient, did he actually have an infection? Did he have a wound infection in your assessment?
So cultures were formally negative from both washouts. Reportedly, and we don't have access directly to the data, something did grow out in the nursing facility during his first stay, but it's unclear if that was an organism that was a contaminant or seeded from elsewhere, because they took only superficial cultures. So he was never confirmed to have an infection, although he did at least partially respond to antibiotics.
Another aspect is this patient had a number of procedures done to try to help his back. He had these minimally invasive interspinous process spacers placed by one physician. He had a dorsal column stimulator placed. What are your thoughts in terms of less invasive procedures trying to somehow confront the main problem of this patient, which is a severe stenosis and a significant functional limitations that evolve around an escalating number of secondary medical problems?
Yeah, that's an excellent question. I think we're a little bit limited here because we don't have direct access to the workup from the initial surgeons. I don't know what their rationale was. It's often difficult to judge another provider without having access to the exact same information that they did. But certainly in retrospect, perhaps a more aggressive surgery to start with may have been appropriate.
What would you do differently in your practice going forth? I know it's like a year from now and I'm putting you on the hot seat here or the hot stand, but what would you do differently in an alternate universe now knowing what you're seeing in this patient?
Well, I think for this patient specifically, I think very aggressive preoperative counseling and any measure of optimization would certainly be indicated. Hindsight is 20/20. Given this outcome, obviously, in my hands, I would do everything I can to avoid this. Encourage weight loss, optimize his kidney function. He's not diabetic, surprisingly, so that's not something that we could work on. That's always an issue with wound healing. But yeah, aggressive medical optimization before any surgical consideration.
For me, the additional point here was the vulnerability, especially of our older citizens, towards delirium postoperatively. This is as of yet, still under-recognized problem. And all things that you stated were obviously part of our prehab process, but we always think about, can we enforce that more? Should we hold off on surgery more to try to optimize some variables? But the key other insight is any time that we can somehow minimize the risk of delirium through anything like medications and mobilization patterns, sensory re-education, et cetera, we can probably help these patients post-operatively. Yeah,
many hospitals have excellent delirium precaution protocols that I think when implemented early can be very effective. In all honesty, I don't know if that was used in his case.
So just from where you were at UCLA, did you have, for postoperative patients like this, elderly patients, did you have a monitoring protocol or a special delirium prevention protocol to let them sleep? And how do you pair the kind of surveillance needs of patients with getting them the rest that they need and getting them reoriented?
Well, realistically, it's on a case-by-case basis. UCLA did have what I think is an excellent delirium protocol. And I think we, especially in patients like this, we did lean more heavily towards reduced surveillance and increased opportunity for rest. I think that was an institutional preference.
All right. Any other thoughts on your end? Rod, you just joined us.
No, I think you guys hit out on all the points. I think my experience has been, if you're going to do something and someone has a problem, either you fix the problem or don't do anything at all.
Absolutely.
So very biased.
I've learned the hard way.
All right. Thank you. Thanks for this thoughtful startup. Next, we'll ask Dr. Jerry Robinson to take the podium, and he has another, but a different angle, challenging surgical case.
All right. Good morning, everybody. My name is Jerry Robinson. I'm one of the Swedish Ortho Spine Fellows here. I did my training in Akron, Ohio at Summa Health. Today's case, patient, 62-year-old male complaining of low back pain with a history of esophageal adenocarcinoma in 2014 was the time of diagnosis, and subsequently had metastatic disease to the lumbar spine, specifically L4. He previously underwent resection of the primary location at the GE junction and was treated with chemo and radiation for his lumbar met. He had a pain pump placed in 2015 that has helped and is still currently working. Despite this, he's had progression of his L4 metastatic lesion and increasing low back pain. Currently, he's complaining of low back pain, left lower extremity radiculopathy, difficulty walking, and reports of occasional bowel and bladder disturbances. But no saddle anesthesia. He also has a history of DVT and currently on Eliquis. Here's a motor score. You can see 47, 45 Asia motor score, mostly weakness in the lower extremities, 3s and 4s, and paresthesias in the left L5 and S1 with 50% decreased sensation. And then it was noted that he has a atrophic lumbar scar from radiation, almost like a burn, 4 by 6 finger breadths with no blanching. And the patient did describe what he said was maximal radiation to his lumbar spine and had some skin issues with that up until now. So there's on these CT scans, if we advance, you have a lytic lesion of the posterior elements at L4 extending through both lamina, the spinous process, the facet joints, and bilateral pedicles. There's no anterolisthesis. You have severe spinal cord stenosis. And then the pump that was previously placed enters at L2-3 and the tip rests at T7. And so MRI was obtained, and you can see a large destructive lesion of the posterior elements at L4 with associated soft tissue mass in the paraspinal musculature. There's complete left L4-5 foramen obliteration due to the mass and severe spinal cord stenosis at that level. And so surgical intervention in January, with the addition of plastic surgery and functional neurosurgery for re-anchoring of that pain pump, as well as the orthopedic spine team. The patient underwent tumor resection, L2-5 laminectomy, L2 to S1 posterior spinal fusion with augmentation with cement at those levels listed, a partial corpectomy for decompression, quad rods, and then plastic primary closure. And so here we can see our construct. And so post-operatively, the patient did excellent. Baseline neurofunction remained unchanged, maybe slightly improved in the lower extremities. The paresthesia and radiculopathy went back to baseline without much pain, and then he's actually voiding on his own. So he was doing great by all measures, and he was DC'd home on post-op day 5. So excellent outcome for a tumor patient, getting him home, return of function, by all measures, doing great. And then I'm actually going to introduce Dr. Gottlieb. He's our plastic surgeon, and he said he would like to present the kind of clinical course from here on how he was able to get this this wound complication on post-op day 22 under control. So here's Dr. Gottlieb. If you just hit this button, it'll advance.
Yeah. Okay.
And I have dates on each one.
Oh, great. Thank you. I couldn't find a pre-op photo, which I remember taken, but it pretty clearly shows an area of dense radiation change. We didn't have an exact measurement of it, except that it was 4 by 8 JCFs, Jens Chapman finger breadths, which bigger than my fingers, probably 5 of mine. I very strongly recall the death and taxes warning that was given by Dr. Chapman and myself, Dr. Chapman particularly stressing how unlikely it was for this wound to heal without later intervention. And he seemed to do okay early on. You can see in the photos that the wound edges started to necrose within a couple of weeks, and it really was limited just to the radiated area. The skin above, skin below did fine. So after some wishful thinking and hoping we could resolve this with local care, we brought him back to surgery, excised. Can I point from here? No.
No, use the cursor on the laptop.
Let's see. Sorry, I'm not used to using this. Well, there's a large flap. It's a skin flap that we designed. We're able to excise the entire area of radiated skin. We try to make these random non-vascularized flaps not much longer than they are wide, and this was about a 1-to-1 ratio. It should have been very reliable. It left a little defect that you can see that needed to be skin grafted at the time, and that should have worked. Unfortunately, we had planned to have the patient in a clinitron bed, which he refused. Didn't really find out till the next morning. He promised to lay on his side. His idea of laying on his side was not quite mine. He was maybe rotated 10 or 15 degrees with pillows right under the flap. He then agreed to switch to a clinitron bed, but undoubtedly the die was cast. And this is the same surgical view. Let me go one ahead. And the whole distal tip of the flap necrosed. Kind of a major catastrophe. And this is a photo after it was debrided. We've already burned one of our major bridges. I spent a lot of time trying to convince any of the microsurgeons at the 3 major centers in Seattle, Swedish being one, the University of Washington, Virginia Mason. I talked to the microsurgeon at all 3 institutions. Nobody was willing to take this on. Nobody had ever had to. There is so much soft tissue available in the back that it's extraordinarily unusual not to be able to use something. The problem here is that he had thoracotomy on the right side, which divided his latissimus dorsi. I was hoping somebody would use the left-sided latissimus dorsi, put a couple of vein grafts between the thoracodorsal artery and veins, and just move it down about 4 to 5 inches to cover this. It should have been very reliable, but I got no takers. While waiting for this, we skin grafted the whole area. The hope was that the area of fascia that you see sitting there would take a graft. That was very unlikely expectation, and it failed, but the rest of the skin graft took. And what you see now is what I did, planning a flap from the right side. It's based distally, which is not really the way we usually would want it, but because he has a thoracotomy incision, approximately based flap seemed unlikely. So what I did here was called a flap delay. We make the incision without elevating the flap and advancing it, with the expectation that cuts off some of the blood supply and encourages blood supply to come from inferiorly. Brought him back to surgery, transposed the flap, leaves a big defect that needs to be skin grafted, which is done at the same time. And so far, he's done pretty well. Shows the graft, that 90% healed. The very tip of the flap, a few millimeters, is dark and probably will auto-debride. And I think this is the last picture, yeah. This is probably certainly the most complicated wound I've taken care of since I stopped taking care of trauma at our trauma hospital at Harborview 30 years ago.
So thanks for going through this insightful, humbling case scenario and your persistence in trying to find a solution. And again, we obviously, from the word go, had a lot of concerns about this patient when we evaluated him. He had a very broad base of very deep soft tissue burn, more or less, through his muscles, even
all the way through to
down to bone. So this was a substantial problem. He had literally had a burned wasteland from previous very aggressive radiation therapy done in the Midwest in a famous 4-letter institution. How can we look at viability of soft tissues clinically? Is there some form of a test, or do we just go with skin blanching?
There are some things that are used pretty widely in microsurgery that look at with intraoperative imaging, look at microcirculation that have been helpful. People have used those in breast reconstruction using abdominal wall flaps. They're probably not going to be applicable for simple skin flaps like these.
Mm-hmm. When we do posterior advancement flaps, like you do a lot of these myofascial advancement flaps, And I know you've just publicly criticized the fatness of my fingers, but they're relatively dexterous.
They're good fingers, yeah. Mine are too skinny.
But so I'm raising my hand here. So the question I always have is, how many centimeters do you realistically have to approximate? Can you or inches, how far can you advance compromised soft tissues immediately?
When they're not compromised, there's not much limit. And frequently, this patient wasn't operated before, but frequently when I'm called to help, the patients have been previously operated. They may already have widely separated latissimus muscles or trapezius muscles. And you could advance those pretty easily by separating them from the underlying paraspinal muscles and rib cage. You can easily get 4 or 5 centimeters from each side. When they're radiated, it's going to be less. And unfortunately, we don't face this that often. I don't recall having the primary procedure on this was extraordinarily difficult, and the closure was tighter than I had hoped. Somehow, despite how poorly that fascia looks, it never leaked. I probably had them 5 times back in the operating room, and it always remained intact despite looking dead.
So we're obviously today in a program that's been sponsored by Ethicon, a Johnson & Johnson corporation, and we're going to talk and learn about antibiotic sutures. But without divulging too much product information in the non-CME part, in the CME part right here, what suture do you use to kind of get this kind of a fascial
I prefer
closure?
using monofilament sutures when I'm called in wounds that are infected or at least ischemic for some reason and high risk to fail. And I prefer using sutures that don't have interstices for bacteria to grow in. I'm interested in hearing what the speaker has to say about the topic today.
I'll ask Rod. Rod was involved in this case also because I wanted some help there. So this was a very problematic case because, again, the more radical we can remove this tumor, the better. The tumor crosses the posterior midline. We knew that there was a very large size 9 gloves here, a defect zone created by, or avascular zone created by the previous excessive radiation, a linear external beam radiation. Are there minimally invasive options to kind of remove this tumor so we can kind of just avoid any incision in this area?
I mean, you could, I think it was L3, right? So
yeah.
I think, going lateral is an option. Perk screws are an option.
But the posterior disease.
Yeah, that's the problem here is how do you get that posterior wall out? And, I've done some case, you can go pretty far back, but the posterior elements, obviously you can't get. So it's not an easy, I think you guys made the right decision. And unfortunately, this is what happens when you get radiation up front.
And it says, this is 7 years surviving with a gastroesophageal adenocarcinoma with metastasis. It's kind of remarkable for everyone who's taken care of him before we saw him even.
Yeah, no, I mean, it's a success story in some ways, but there are sequelae to be dealing with later that are quite difficult. So thank you for all you do, and thanks for this review. From your end, Jerry, as you looked at this case, is obviously a very difficult case that shows how many different factors come into play from just a systemic fashion. Again, what would you have done differently outside of not operating on the patient, which for him, by the way, we had multiple very hard visits with him, and we had a joint surgery with neurosurgery and orthopedic surgery in this case to try to facilitate the case, plus plastic surgery. What would you do differently?
The only thing that I didn't see in the notes, there was use of wound vacs, which I am partial to, that I like that decision. I think that's kind of changed the game with wound management. The only thing I can think of that might have been helpful was I've seen hyperbaric oxygen. I don't know if that would be helpful in this situation, but that's something to consider, I guess. But otherwise, I think that having a multidisciplinary approach with plastic closure from the very beginning was the correct call. And I'm not sure that we could have done a whole lot different in regards to optimization or post-operative care. By all measures, the guy went home and was doing great. So it's just the nature of the beast, I think.
And as you're looking at him now neurologically, he came because he got progressively weaker. How's his functional status? How's his mobility status?
Yeah, he's actually doing much better from a pain and functional standpoint. No mechanical back pain. while moving. He was I believe, almost exclusively bound to a wheelchair by the time he was to us for surgical intervention. So I think that he's now up in a walker and kind of avoiding the sequelae of being immobilized. So I think by all measures, he's done extremely well.
Well, thanks for this thoughtful review and again showing us these shocking and impressive pictures. By the way, we did talk about transabdominal flaps and all sorts of other soft tissue things. And due to his previous history of abdominal surgeries, radiation, all of our microsurgeons in the area said no towards doing one of those transabdominal or transrectus flaps where they basically do a pull through. I've actually been involved in those. We also talked about a large lateral release where basically cut anything from the axilla down to the pelvis and then slide everything over. And we also said no to that due to this previous thoracotomy. So there were conventional other options that were certainly considered, but due to his circumstances were implausible. Thank you, Jerry. And next we have Dr. Pratt, I think. Do we, just for timing's sake, have one more case, or are you the last case?
I'm the last one.
Good, okay.
And it's not very long. I just have a couple of quick.
Well, Dr. Skuin and I will be the determinants if it'll be a long case or not.
Oh, okay, I'm sorry. It might be long.
Can you introduce yourself, please? I know your jacket shows where you're from. Just tell everybody where you're from.
I'm from University of Maryland Medical Center. Thank you.
And your name is?
Nathan Pratt.
Dr. Nathan Pratt.
Nice to meet everybody this morning. Sorry.
There's a faithful online community that keeps track of who's speaking here. So
oh, gotcha.
We thank our friends from around the world. I see many regulars from all the way from the People's Republic of China to the Mideast. So thank you for joining us, to Latin America.
Thank you. Okay, so this is a case of an epidural abscess that Dr. O and I took care of a little while ago. And so SP is a 66-year-old female with an extensive medical history, IV drug abuse, hypertension, COPD, aortic and mitral regurgitation, atrial fibrillation, failure to thrive due to multiple problems in terms of nutrition as well as her COPD. She was transferred for an epidural abscess extending from T11 all the way down to S1. Unable to ambulate due to severe low back pain as well as leg pain. Subjectively, the patient was reporting weakness and reports of incontinence, though it appeared to be due to her inability to ambulate. Unclear if it was because of compression. She had multiple prior admissions for COPD, vasculitis, and bacteremia at other facilities. Otherwise unremarkable history. The physical exam of the patient was very thin. She had full strength in her upper extremities and was full strength in her distal lower extremities, but her bilateral iliopsoas and quadriceps were 4 out of 5. Sensation was mildly decreased throughout the lower extremities to light touch and pinprick, and she had some hyperreflexia in the distal lower extremities. So here's a mid-sagittal MRI. You can see she also has a significant scoliosis, but the most significant area of compression here is the axial slice there at T11-12. And that was obviously the area that we were most concerned about, although she has severe compression throughout the canal all the way down to certainly L4-5 and even L5-S1 as well. So the key point to this in terms of the management and attempts to avoid surgical site infection, the patient had severe compression, definitely required some sort of surgical intervention to try to preserve her neurologic function. The major concerns from the anesthetic team, given the mitral and aortic regurg, as well as the evidence of the abscess on both valves, they were quite concerned the patient may not make it off the table, but optimized things as best they could. As well as her hypertension, overall medical condition necessitated a more efficient surgical approach to try to limit the size of the operation. Instead of performing a full laminectomy all the way from T11 down to S1, we made 2 smaller incisions. Laminectomies were then performed T11 to L1 and really L3 to L5. Then an external ventricular drainage catheter was passed into the intervening spaces, and irrigation was used to clear the abscess with a much smaller operation. So the EVD catheter is relatively not as thick as sort of like a red rubber catheter or something like that one might use. So it can be easily passed underneath the lamina, the intact lamina at the levels above and below the laminectomy. You can use a smaller incision leading to better wound healing, lowered likelihood of infection. The case was shorter, which is good for the patient who is bacteremic and septic because She actually started to pericode as we were closing this case and had to flip her very quickly because of that. We can get adequate decompression observed in the operating room by continual irrigation with no more purulent fluid arising. It may be less effective in cases of phlegmon or severe underlying degenerative disease if there's too much stenosis to pass the catheter. However, in a case like this with a relatively large abscess that's clearly liquid throughout, it's a good technique to consider that I haven't seen used extensively in the literature or anything like that. So the patient demonstrated multiple risk factors for poor wound healing and surgical site infection. She had an active infection, IV drug abuse, poor nutrition, COPD and heart disease, immobilization, and the idea was just to decrease that risk as much as we can. I just have a quick, there's a paper because it's a relatively short case just to mention a meta-analysis to look at surgical site infection. Patient risk factors included comorbidities, which this patient had, poor nutritional status, smoking, BMI, obesity, which was not this patient's problem, obviously, and then thicker soft tissues which would retain bacteria. And then finally, the surgical factors increase operative time, likely increase the risk, but no specific time at which there was some sort of threshold was identified. The approaches, combined anterior, posterior, higher risk, minimally invasive or less invasive surgeries appeared to decrease the risk in elective cases, but not necessarily in this type of patient or in a trauma patient. And then invasiveness of the surgery, which is based on an index, was not definitively associated with surgical site infection. So again, the idea to reduce the size of the infection, decrease the burden on healing.
Can you go back to the title page for the article that you just quoted?
Oh, yes. Yes.
Dr. Street has been a frequent speaker here, and Brian Kwan, and I think both of them will be back at our trauma course. I think it's the 7th or 8th annual spine trauma course this winter, but they're wonderful researchers. They're from VGH, so Vancouver General Hospital, and the University of British Columbia there. So this is a very important study for me, but what it lacked was, if you can go back to that title page, please. What do we best use for closure in these at-risk patients? I lacked so I'm being respectful to these wonderful authors, but I did not have a tangible outlook. I'm going to pass my microphone off to Dr. Gottlieb. So let's start at the skin. We're going to hear about antibiotic-laced sutures shortly, but what's the best skin closure for the posterior midline integument in a compromised patient?
Yeah. If the edges are lined up and there's no tension on them, I think putting staples in is less traumatic than anybody's suture technique, no matter how delicate they are. So that's often my preference.
Okay, you're an experienced plastic surgeon. I'm going to hold back against you, okay?
Okay.
So in my experience, even with the best wound management, staples have a finite life expectancy of maybe 10 to 12 days. Is that a fair statement? They get reddish around their corners. Why is that?
Some people have metal allergies. Most of these, when I take them out, are not red.
So my point is
10 to 14 days.
I'm sorry, I'm cutting you off here. So we usually, for posterior midline healing in impaired patients, need, and Tanya's sitting behind you, need probably about 2 to 3 weeks
and that's
something
correct,
in there. Staples usually, and that's my point, have a less than 2 week survival time until the edges start getting inflamed. And I'm gonna hold strongly against you. This is not metal allergy. I've actually done a published and then non-published research from that and had to withdraw a grant because of what we found. Metal allergies are frequently accused. It's not metal allergies. It's a micro motion induced hypersensitivity of the skin, probably a super infection of the skin where the metal meets the skin and rubs it. So that's what we were told at the time. So I'm worried about staples not having the longevity that we need in compromised patients with posterior midline incisions to get the appropriate maturation of the epithelialization. So that's my worry. So you think staples are better than sutures?
If the skin edges are not touching, and I pretty much always, you're not always there at the very end of the case. I pretty much always have an intradermal closure, subcutaneous layer, again, of one of the various monofilament sutures. And you actually can put steri-strips over those. I wouldn't do that on a back, but in other parts of the body, that's the last level of closure.
Okay.
So I think pretty much anything is satisfactory so long as it's done atraumatically.
So the other question I have along those lines is subcutaneous closure. So there have been manufacturers who have now brought out these barbed sutures that were supposed to be much better resorbable. I don't want to mention product names in this CME part, but do they have an advantage over conventional knots and ties? They're monofilament, they're barbed.
The only advantage is not having knots. Occasionally the knots spit out and you wind up having to trim them, but otherwise they don't have any particular advantage. They're easier to put in sometimes because once they're set, they're not going to pull back. You don't have to worry about keeping tension on a continuous running suture.
Did they, as they rolled out this product, have comparison studies that showed wound healing? And like this patient that Dr. Pratt just presented is a very compromised host?
Not that I know of.
Rod, we've stopped using those barbed sutures. What was your experience clinically? This is, again, very anecdotal.
Yeah. I mean, I think, you know, I just like regular sutures because I didn't feel like they were, for whatever reason, you know, it's kind of like PDS. You know, I think if you have a absorbable suture for whatever reason, you know, I think you get, at least what I saw is that the skin wasn't really healing as well, and the suture was starting to loosen. It was almost like a nylon suture. And I think, you know, with that kind of closure, that's why I don't like running nylon sutures, because usually what happens is the distal end of it is tight and the proximal end starts to loosen up. And so you get this differential. And I think that was my experience with those type of sutures.
See, I've not been a fan either of these barbed subcutaneous sutures. Now, let's talk about the subcutaneous tissue plane in a compromised host, again, like Dr. Pratt's patient. When we have obese patients, we obviously have something called scarpous fascia, but something that we find frequently is that the fat seems to necrose and colliquate. So is there a benefit in having a multi-layered closure? Should we have a separate subcutaneous drain to anticipate this fluid collection subcutaneously that we then want to siphon off? Tell us a little bit about how to handle a large integument.
If there's a scarpas layer, I usually try to close that in an obese patient. And I don't think it's only called scarpas on the abdomen, but it's the same layer if you can find it in the back. There were lots of studies, boy, they were being done when I was a resident in the 70s in Charlottesville, showing that putting extra layers of sutures in the fat layer only increases the chance of wound infection, and they give no structural integrity. The fat just sitting next to each other is perfectly satisfactory. Adding a suture only adds a nidus for bacteria.
Should we drain the subcutaneous space separately?
In a large patient, I frequently do that. In a morbidly obese patient, yes.
Okay.
Often they can come out in a couple of days, but if they're putting out a lot of fluid, you're glad you have them.
Now, one big learning thing for me after crossing over from the university now over 7 years ago was, and again, I don't want to use product names here, the use of a very slow resorbing monofilament suture as opposed to the conventional threaded, braided suture that everybody uses that starts with a V. Usually. What's the benefit of having a slow resorbing suture in your eyes, and how did you discover this? Was this published somewhere, or is this just empirical?
Part of it's empirically. I mean, for me, it was a patient that had an abdominoplasty with braided nylon, closing the deeper layers, and I probably had to do 10 INDs on her in the office before I took her back to surgery, opened the whole field, and took all the sutures out. The long-acting monofilaments last long enough to have wound healing. They don't need to be there forever. Once about 6 weeks has passed, the tissues are healed and have reached about 90% of the tensile strength, not of normal, but of as much as they'll reach. And that certainly at least as much as the sutures will hold. So you don't need something that lasts forever. You need something that lasts until wound healing happens. And it's best if they dissolve and go away.
Now let's go to, thank you, Jordan. Let's go to Dr. Pratt's experience at the University of Maryland. So you have, and many of your professors have been lecturers here at SSF. You deal with some very complicated patients also. So what are your kind of go-to closures when you have a compromised host and you have a more extensile posterior incision, especially posterior midline?
Right. So I agree completely. I think that the key is that layered closure to make sure that you're closing muscle, fascia, and then subcutaneous tissue. We use almost exclusively braided suture with either both interrupted and a running stitch as well, with a needle like a UR6 that would allow you to run in addition to interrupt the fascia. For these subcutaneous layers as well, also interrupted sutures. And then on the skin, a lot of times either a running vertical mattress, or again, Dr. O's concern, that might loosen interrupted vertical mattress sutures spaced pretty generously and then staple in between those, or a horizontal mattress spaced a little bit closer with a fair amount of tension, but not too much so that you don't necrose that skin edge as well. But that's what we've done in the past with difficult to heal wounds.
So for
and then an incisional back a lot of time too. Yeah.
Did not mean to cut you off.
No, go ahead.
For oncologic patients where radiation is anticipated, who are probably also malnourished, and there's something else I wanted to bring up, do you use nylon then?
Yes.
Do you keep the nylon in for
usually
6 weeks, 3 months?
3 weeks to 4 weeks, just depended on how it was. I mean, the only problem leaving it in that long that we had was trying to dig the sutures out afterward, because a lot of the time the skin would heal pretty well. And then particularly for a vertical mattress, oftentimes you are grabbing a 15 blade or 11 blade and trying to dig that suture out. So I think usually our maximum, was probably about 4 weeks, unless it just really looked like it wasn't healed. And oftentimes if it didn't look good at that point, we would probably call one of our plastics colleagues. Dr. Rasco did a bunch of our closures back at Maryland and let her have a look at it and try to figure out if we need to go back and at least do a superficial revision at that point. But yeah, that was generally what we did.
So we'll probably have a chance to go for a deeper dive when we have Dr. Ovington speak. Mm-hmm. And I'll just ask our command and course, is Dr. Ovington online yet, Ben or Linda? So carrying on with the questions right now, how did this patient actually do? This patient who has an obviously significant bacterial load, what was the organism? And tell us a little bit about how the patient actually did.
This is MRSA. Unfortunately, so neurologically from this operation, the patient did well. Her back pain was a little bit better. Her leg strength improved. Her incontinence went away to the extent that we knew her bowel function was good, her sensation was better. However, medically, her condition deteriorated. She had multivalvular heart disease in addition to her COPD. She was extubated on post-op day 2 and remained in the ICU. The cardiac surgery service considered doing a 2-valve surgery on her. However, they were concerned that she may not do well. And unfortunately, because of her sepsis and multi-system organ failure, she actually went to comfort care and passed away. I think that, it's hard to know what's going to happen beforehand. So I think that trying to do something small or as small as possible to fix the problem was a good idea, despite the poor outcome. There was nothing we could really do about that, unfortunately. But yeah, she did not do well medically, but neurosurgically or spine surgery wise, I think she did pretty well.
So removing the bacterial burden for the host was a big deal and is a very big deal and critical. In terms of radicality of infection erasure, Rod, I'll give you the microphone here. Is there some magic number of liters that you use, or how do you make sure you don't have, for instance, an empyema that is socked in somewhere around the dura?
I mean, that's a great question. We typically use about 3 liters, sometimes more. There's no magic number. In this case, I think we drained, it was just like purulent pus, 30 to 50 cc's of purulent pus came out. So we just irrigate until we see it kind of clear up. But with the dura, the spinal cord, I think using the EVD catheter was key because we were able to make 2 small incisions and get a lot done. And she came in pretty sick. So I think it was a good option at the time. We couldn't do a bigger surgery because of her heart.
So this is obviously a very important case to show because we're burdened with more and more of these very ill patients, and the spine is like a last manifestation location for the severe illnesses that these patients frequently face. Was there any wound healing problem in this patient who had liquid pus floating around her, substantial parts of her spine?
Not really. There were some kind of superficial serous drainage that was going on. We were doing dry to dry dressing changes every 12 hours. So the nurses at least were getting a good look at it. We were in the mornings. But I mean, she only survived probably 2.5, 3 weeks. So, I mean, that's long enough that the incision was healing up pretty well. The staples probably would have been coming out about now-ish, because it would have been about 3 weeks. Well, now it'd be 4 weeks. It would have come out near the time for passing. But, we didn't have a big problem with wound healing. I did not use suture. I used staples and did an extensive braided suture in both the fascia, a few in the muscle to just pull that layer together, the fascia, and then the subcutaneous as well, using a lot of those braided sutures that were, I believe ours are antibiotic impregnated, and then stapling on top of that. So,
final couple of minutes before we switch to our guest speaker in the non-CME part of this presentation, nutrition. So do you remember offhand what the patient's albumin was, and how at the University of Maryland did you determine that?
I don't remember what hers was. We didn't routinely check a pre-albumin on all of our patients, though that is probably something that we should do, because I think it was definitely, it was low.
Yeah,
she had high blood pressure.
It was like 1.5 or something.
Very low. I mean, she was not eating at home. Yeah. She was, again, COPD, so she's using a lot of force just for her respiration, and she obviously had this infection in IVDA. So mostly what she was doing was either snorting or injecting drugs and not really eating anything. So very.
So we have Dr. Schonert on our panelists, but he's starting to scrub, so he can't speak right now. But at UW, we actually had a grant that we got accepted for preoperative nutrition to try to help wound healing and posterior backs. And we could not get an agreement of experts, content experts in the field, of what the best chemistry parameters to predict wound healing. Some of them were way too expensive. Some of them were way too long in terms of getting an actual test result.
Right.
In the end, we settled on simple albumin as a screening tool, not pre-albumin, not transferrin, but simple albumin as a screen. And I was going to ask Dr. Schonert, but I'll just comment then on his stead unless I hear back from him right now. Yeah, he's just texting me, so he's starting to scrub. We found in a statewide database that he helped found and that he ran for many years very successfully, albumin 3.5. So if you have an albumin 3.5 or higher, you have a good propensity towards wound healing from a nutritional state, and total lymphocytes count 1,500 or higher. So those are the two parameters that were statistically, and thank you, Neil. Sorry we can't see you live right now, but you're doing your work in the OR. Have a good day in the OR, and thanks for texting this. So those are the two parameters that in a very large statewide database with over 15,000 patients were predictive of posterior wound healing. So as we're going to do a deeper dive in terms of suture materials and what can we do to reduce wound infections and surgical dissection technique and maybe less invasive surgeries and more intelligent retractor use, nutrition counts a lot, especially in severely compromised patients. And again, as a screening tool, these are still probably the best numbers that we have that are immediately available, that are not super expensive and add additional test burden to patients. So, but did you use that in Maryland, these numbers?
Not routinely. It just depended on the patient, but no, we did not routinely.
Because one of the oncologists from the center, I don't want to put him out here, always said that they did do that in their oncologic surgical care. But yeah, so those are the numbers: albumin 3.5 and lymphocyte count 1,500. Any other insights from your end on this case? Would you have wanted to do more or less? Would you have done something differently now in retrospect?
I still would have operated. I think clearing the bacterial burden is worth it, unless unless cardiac surgery or somebody told you there's no hope, this just doesn't need to be operated on, there's nothing that's going to fix this patient. But if there's any hope that they're going to recover, then you have to protect her neurologically. The only other time I've seen the catheter used like this, we had a case at shock trauma that had an abscess that extended from the cervical spine all the way down to the lumbar spine, that we did a similar type of approach. And well, that patient didn't do very well. He was already quadriplegic by the time we operated, but we tried something because he was young. But similarly, I mean, this is a dire situation. I don't think that there was anything else that we could have done differently here. And I think I would do the same thing again if faced with this. So.
And Dr. Sean is just texting, he's saying that modifiable risk factors are only useful if used pre-op in an elective situation. So you presented a acute case, so there we can't modify anything.
Right.
We have to do what we have to do, and then hopefully with excellent soft tissue management technique, avoid a wound healing problem. And that seems to have not been her problem.
Right, that wasn't the
in a
issue.
worst case scenario. Well, thank you, Nathan. And we'll switch to our non-CME part. So Dr.